Hello and welcome to another live broadcast with MedStar Health. My name is Michelle Carter, and today we're talking about the benefits of therapy when it comes to sports injuries. It's National Physical Therapy Month, so now is the perfect time to discuss how PT and sports medicine collaborate to provide the best outcomes for patients. So give us a like, let us know that you're here and you're watching. Share this broadcast with your friends. And if you have any questions along the way, please share those in the comments because we're going to take some time to address those too. Now let's meet our experts. First, we have Rebecca Schumer, physical therapist. Becca, will you tell our viewers a little bit about yourself, your specialty, and what attracted you to sports medicine?
Sure. So I've been a PT for about 14 years, graduated from GW, was there for 7 years, played two sports there, two D1 sports, soccer and softball, and that's sort of what kicked me into the sports world. I was always fascinated with the human body and saw my teammates getting injured before I was, and then really just was like enamored by the healing process and how they like what it took to get back to doing what they love to do. And that's sort of how I fell into PT. And once I had PT in my brain, it was just like tunnel vision. That's what I'm going to do. It's sort of rare to hop into a sports PT job as a new grad, but I really lucked out and have been pretty much treating athletes since I started in the field. So love it and happy to be here.
Wow. Thanks again, and thanks for joining us today. We really appreciate your time. And now we also have Dr. Allison Fillar, sports medicine surgeon. Dr. Fillar, could you please introduce yourself as well to our viewers?
Sure. So, Allison Fillar, nice to meet you guys. I also went to GW for my undergrad, played softball there. I did a master's degree in the medical school there as well. So lots and lots of years at school. My dad is actually an orthopedic surgeon. I tore my ACL when I was 15, so I had a very early introduction into the world of sports medicine, going through that myself and then going through the rehab process. When I decided to go to medical school, I actually wasn't sure if orthopedics was going to be the right field, but as soon as I had the opportunity to get into the operating room, really realized that it was something I was really passionate about. It really let me combine a lot of the things that I was interested in, both from an anatomical perspective, but tying in some of the experience that I had also with sports medicine. So for me, it was very gratifying to be able to meet with a patient, or the idea of meeting with a patient having a problem and potentially being able to come up with a solution for that.
I love that. Thank you so much. I really appreciate the both of you for taking the time out for this. Let's dive into some of our questions. So you both provide different forms of treatment to patients in the spirit of collaboration. What skills or knowledge inform you the most about others' field of expertise?
Beck, you want to go first? I think I've always felt that there's a huge collaboration between orthopedics, particularly with sports medicine, but across the field of orthopedics, and finding physical therapy to be an incredibly beneficial tool. I think it can help. For me, I feel like when I'm talking to a patient, not everything is a surgical solution. So I think sometimes recognizing that and being able to work with patients and being able to offer a full complement of operative and non-operative treatments is hugely beneficial for all of my patients. So I think having a great working relationship with the PT is in everybody's best interest for sure.
Right. And with direct access, that patients can come off the street and see us without having seen a doctor yet. So if a patient comes to us and they need more help or imaging or just another view, it's nice to have those relationships with our surgeons and doctors, sort of streamline that to get them the best help quickly. I can't do my job without her, and hopefully she thinks that she can't do
anything.
So it has to be collaborative to optimize how we treat our patients and athletes.
Absolutely. I love to hear about the teamwork going on at MedStar. So great. What are the most common sports injuries that you see?
I don't mind taking this. Beck probably sees even more than I do in a way, but so for sports medicine, I primarily am dealing with knees and shoulders. That's the vast majority of the injuries that are coming in. Obviously, people can injure their hips and their shoulders and their ankles and everything as well. I see a lot of patients with torn meniscus, ACL injuries, cartilage injuries, patellar dislocations or kneecap dislocations. I also see a lot of patients with shoulder injuries, whether they've had a dislocation or a labral tear, or if it's some of our older athletes, a rotator cuff tear, things like that.
And just echoing pretty much the same. See a lot of patients after ACL surgery, hypermobility, shoulder instability, rotator cuff issues, hip pathologies. I mean, the list is endless.
All right. And I think you sort of touched on this a little bit, Becca, what are the type of movements that could cause these types of injuries that you guys see?
There are many types of movements that can cause injuries. For instance, like the ACL is a more common one, just plant, cut, twist, pivot, there goes your ACL. That's a common one, but also just in sport, athletes put their joints in extreme range of motion sometimes, and if they're not ready to handle that load, then an injury can happen.
Okay.
I agree. I
Dr. Fillar?
think, I mean, even sports where people are, on their own, it's golf or it's tennis and you're not a contact sport. I mean, obviously you can have an ACL tear. I also think that there's a component of repetition for some athletic injuries as well. So it doesn't necessarily have to be that something immediately bad just happened within a 10-second decision. You can also get overuse injuries. And I would argue that in that situation, particularly physical therapy can do a great job, not just in dealing with the injury when it happens, but actually also helping with prevention of injuries as well.
That's good to know. Good to know. I feel like physical therapy is like that first line of defense when it comes to preventing or recovering from injuries. What sports? I'll direct this to the both of you since you both have a sports background. What sports seem to have the most risk?
It totally depends on the injury that you're talking about.
Okay.
So every sport, I guess, has a more common injury that's associated with it. Like lacrosse, there's a lot of back injuries, soccer, a lot of knee injuries, gymnastics, ankle sprains, dislocations. Dr. Fillar, what else?
I mean, baseball, like throwers with like overhead athletes are going to be more predisposed to having a shoulder injury. So I think that there's a lot of literature that's out there, both from an orthopedic perspective, but also in terms of like the PT literature that's out there, where they have really looked at that and been able to isolate particular injuries. We have a reason that we call it a golfer's elbow or tennis elbow because you see those injuries, particularly with that sport. So I think that there's a lot of awareness now, particularly on team sports or those individual sports where you are trying to do everything you can to avoid that happening.
Okay, good to know. Do you see any difference when it comes to who has sports injuries more often? Do male athletes or female athletes tend to have more injuries? Are there any anatomical differences that could contribute to them being injured more?
I think the one that everybody always talks about is the ACL in this situation. They have done in terms of the orthopedic literature, the ACL is certainly one of the most studied topics. It has the highest number of publications that are available. And they've certainly looked into the incidence of ACL injuries in the younger female athletic population as being at higher risk than the younger male population. They've hypothesized that for a number of reasons: hormonal, muscular control, dynamic body control. That can probably attest to that as well. So I think that there's certainly an indication or, a feeling that, as a young athletic woman, you're at a higher risk for having an ACL injury. But again, I also think it's very sport dependent. And, I talk to patients all the time, especially my athletes, when they come in and they're like, it's like a split second, 10-second decision, a 30-second thing that happens that puts that body at increased risk for an injury. And, it's always one of those things in hindsight, you're like, oh, I wish I hadn't done that particular thing. But I think any athletic pursuit has that theoretical risk.
And it's hard, right? Because they've done that same move hundreds, if not thousands of times, but that one moment, just the right amount of force, right amount of stress, the wrong time.
Yep.
Okay. And what's the impact on the rest of the kinetic chain? In other words, if the knee is out of order, how does the athlete's body have to compensate for that?
Our bodies are really good cheaters. So if we can't use
this is why I have Beck. This is why I have Beck to refer to, because people do definitely make adjustments.
Yeah. So if you can't use like part of your body or something's in pain, your brain's going to try to avoid that at all costs and try to make us feel better. And then we're going to compensate and other things get affected. So yeah, it's important to not just look at the joint that's involved, but really the whole body of the human that's in front of you to, if they're say they're having a surgery or they have an injury and they can't necessarily put a lot of weight on that specific joint, there's so many other things and exercise we can do to address other issues to make sure that other things don't become a problem or they don't get compensations that are really hard to break later on. So really it's like a full body process that we're going through.
Okay.
Agreed. Jokingly, but I tell everybody I have a 5-year-old daughter, and there's that song Head, Shoulders, Knees, and Toes.
Yes.
Everything's definitely connected.
Yes. How does an athlete know if their injury will need medical care? Like, what are the symptoms that they should be looking out for that they really need to get this checked out?
I think anytime anybody feels a pop, a snap, they're like, if somebody says I had something and all of a sudden I knew like I could not continue playing, if they have to come off the field and they're not able to return, that would certainly be one. Those mechanical things like the popping feeling, if people have a lot of swelling in the respective joint, if they have difficulty or pain with weight bearing or range of motion of any particular joint, certainly I would get those assessed.
From a more chronic standpoint, if activities that were once pain-free are now becoming worse and worse as time is going on, or if you notice that you're starting to like lose your ability to move your arm or whatever body part it is through full range of motion, things are swelling and not reducing, the pain's increasing, things like that are good times to go get it checked as well.
Okay. And let's say, that the worst has happened. For example, an athlete heard that pop sound and thinks that they may have torn their ACL. Where should they go first? The ER, urgent care, primary care specialist? What's the first action they should
I
take?
don't know that there's a wrong answer here.
Okay.
I think it's just trying to get access into medicine. I know, if you go to an urgent care, or if you go to an emergency room, I mean, one of the first things that I like to do is get an X-ray when I see patients in the office if they have not already had that done.
Okay.
Obviously, anything mechanical, you want to make sure there's no fracture or anything underlying, no bony injury that's underlying. So if there is that concern for an acute injury, if you go to an urgent care to an emergency room, that's what they're going to primarily do. They're also equipped to deal with those more acute emergencies. So if the x-rays are okay, the emergency room or an urgent care may provide crutches or brace or ice or anti-inflammatory medications to kind of help reduce inflammation. If the ER wait time and urgent care wait time is really high and you have more immediate access to your primary care doctor, you can obviously call your primary care and get in. If you already are seeing a physical therapist, certainly you could get in touch with them as well and have them evaluate that. You can call an orthopedic surgeon and get that appointment scheduled as well. So I would just say probably whatever the most direct point of care is, to kind of alleviate any stress or anxiety that the athlete or the patient has as well is important.
That's also another benefit of having relationships with doctors. So often we've seen these kids before or adults, whoever they are, and they've seen us, they've been hurt, something happens, we're often the first people they text or call when something goes wrong. And then we have hopefully easier access to find the right person to send them to get their eyes on it quickly.
I agree.
And I think, Dr. Fillar, you touched on this a little bit about getting that x-ray first. Could you elaborate more on how these injuries are diagnosed?
Sure. So it depends on what the body part is, but let's say we
Okay.
take an ACL tear, for example. Usually that patient will feel a pop, they'll have a plan, a pivot. Occasionally people will have a contact injury. They may have swelling. They may not be able to comfortably weight bear, decrease range of motion of that joint. So the history of how the patient describes what happened to them is incredibly important from a diagnostic standpoint. Once you have the x-rays, you're going to check and make sure there's no fracture, depending on the age of the athlete. They may have open growth plates. It may be an older athlete. You may have a little bit of arthritis. So those x-rays are going to be really important to be able to kind of rule in or rule out those other types of ongoing issues. The physical exam. So when I meet with a patient, obviously we'll talk about everything. We'll do the imaging in the office, and then I'll do a physical exam. So there are specific maneuvers that we can do in the office to kind of assess and see what the integrity of the ACL is. Same thing if we're trying to address any other type of ligament injury or a patellar dislocation, or if somebody has a shoulder dislocation, there will be specific physical maneuvers that the provider will do in the office to kind of confirm or, check and see what the stability of those ligaments are. Every day of my life, I tell everybody I wish I had MRI vision. So an MRI is certainly going to be incredibly helpful in the vast majority of these athletic injuries. X-rays are very helpful to be able to see the bones, but you can't see any of the soft tissue. Can't see the muscles, the ligaments, the cartilage, anything like that. So usually the next step in terms of a diagnostic criteria would be to get the MRI.
I like to ask people, like, what superhero power, like, what would you have if you get anything? And I always say MRI vision.
Me too. It's the nerdiest thing, and I am glad we're on the same page as that, but it's definitely true. I every day of my life, I wish I had MRI vision.
Yep.
Good one, good one. Mine is flight, the power of flight. I like to fly. Well, thank you both for that answer, and for shedding light on sports injuries, the diagnosis process, all of that. Let's take a moment to welcome our viewers again. We really appreciate you guys taking the time to watch this Facebook Live with us. It's National Physical Therapy Month, so now is the perfect time to learn more about preventing sports injuries, how to be proactive about getting that recovery that you may need. We're live with physical therapist Rebecca Schumer and sports medicine surgeon Dr. Allison Fillar, discussing everything you need to know about sports injuries. If you have any questions along the way, please share those with us in the comments. We'll take some time to answer those as they come in. So I have a few more questions of my own, so let's get back to those. And I'll direct this both to you. You guys are doing a great job of tag teaming with the questions here. Questions about treatment. What does the treatment process look like? Is there such a thing as conservative treatment, or, and to what point, at what point is there surgery that's necessary at some point?
Yeah, I'd be curious to hear from you, Dr. Fillar, regarding like what % of your patients that you see in a week could end up having surgery versus you refer to PT for conservative PT or conservative treatment.
I think it depends on who's coming into the office and for what reason. It's
Okay.
like things kind of come in waves. Like I'm sure you recognize this too, like at the beginning of athletic seasons when kids are getting back into their, respective sport, like beginning soccer or like the spring season for lacrosse. I feel like there's like a bump up in terms of injuries, and then it kind of calms back down. The more chronic things tend to happen a little bit later in the season. So it really just depends on the season and where you are in that particular season, and probably what sport it is. I personally feel like there are certain things within orthopedic surgery that are a little bit more black and white in terms of injuries. So if anybody watched football this past weekend, there was a Detroit Lions player who had a tibia fracture, and as a surgeon, it's relatively straightforward in that situation to say we should do a surgery on this to get him up and moving more quickly. But I certainly see those chronic injuries or even acute injuries where, we can certainly talk about non-operative management first. You can try and do all of that first to help stabilize the joint, reduce inflammation, help with pain, help with dynamic muscular control. And it may be a situation where surgery is a theoretical option, but the patient doesn't necessarily have to go through with that or does not need to have a surgery. So I think for me, the important part of my working relationship with Becca and our other really wonderful physical therapists is that we have that good relationship. I know that when am sending a patient for physical therapy, that they're going to be working with them, not just on that specific, body part, but the whole person, like Becca mentioned before, to try to get them through whatever this injury was and potentially avoid having to have a surgery.
Especially like with the conservative treatment, oftentimes it is more the chronic thing. So sort of reviewing their habits, posture, like what kind of got us into this situation and what behavior change can we make to sort of avoid that happening again? So yeah, conservative is definitely number one.
Yes.
Okay.
So for example, let's say there's a labrum in the shoulder and there's a labrum in the hip, and both of those are like an additional elastic kind of soft tissue that helps stabilize the joint itself, but they can get injured, in runners or in football players. And sometimes when a patient comes in and they're symptomatic from that labral tear in their shoulder or their hip, we try a course of formal physical therapy before we consider going in and doing any kind of stabilization procedure, because some people will definitely get better with non-operative treatment. So it seems that if you are one of those patients and you can go back to the stuff that you love, you can go back to athletics, you're pain-free, you're being able to return to all those activities, I would definitely not do a surgery in that situation.
We love
But it
our
also,
surgeons. Yeah, go ahead.
yeah, no, go ahead.
We love our surgeons, but like when we avoid the OR, like that's the huge win.
Yeah.
Yeah, I agree. I agree from the patient end. I agree
Yeah.
with that. No
Yeah.
offense.
And well, I was going to say, I do think that there are certain injuries that can come in, though, that I think if Beck saw like a teenager with a flipped over meniscus tear, she would probably say, I do not want to do physical therapy. You need to go and talk to a surgeon. Or somebody is 18 years old and they've had a shoulder dislocation. You know, I certainly think that there's a conversation to be had about operative and non-operative management
Right.
for sure. And some of those are a little bit more acute than others, but we have great PTs that recognize that. So.
That's great. I think that's a perfect segue to my next two questions to the both of you. So I'll direct my first one to Rebecca. What types of injuries or conditions are best treated with PT? And then Dr. Fillar, if you could share which ones are best treated with surgery.
Sure.
Yeah, I think Dr. Fillar sort of just covered this a little bit about like the more traumatic, obvious things that need surgery, but conservative, like ankle sprains, shoulder rotator cuff tendonitis, all those things are better to be treated conservatively. Those chronic conditions, again, sort of reiterating what we just talked about, those more chronic things that we can sort of look at, like what got us into the situation and what tools can we implement to get us out of that situation.
Okay.
And then from a surgical treatment perspective, you could have the same injury in two different people, and one may be a good indication for surgery, and then the other patient may say, I'm not interested in doing that. So I think knowing that in certain circumstances, you can have an athletic injury and there will be pros and cons of non-operative treatment, there'll be pros and cons of operative management. The surgeries that, you know, we are much more inclined to take more quickly to the operating room be something like that bucket handle meniscus tear that I talked about. So if you think about your meniscus being two C-shaped structures that sit inside of the knee, if it flips over on itself and now you have what we call a locked knee, meaning you cannot flex or extend your knee, really the only way to put that back into position and give it the best chance of healing is to consider doing a surgery. And we like to do that sooner rather than later. You want to try to preserve that function and integrity of the meniscus. So there are certainly things that come up. You know, somebody who's 40, 45 years old with a traumatic rotator cuff tear, they fell off of a ladder, or they had a traumatic injury, we may be more inclined to talk to them about surgery quicker as opposed to non-operative management. But again, it depends on the patient, the indications, pros and cons of surgery for sure.
There's very little that's off limits for the PT world for us to see. We see a lot of things, everything.
Good. Full range of treatment options here. Yeah. Excuse me. Since, you know, keeping in on the topic of the conservative, you know, non-operative treatment options, Becca, could you share, let's delve a little bit more into the physical therapy process. Could you share what exactly is physical therapy? What are some of the expectations that patients should have? Is it painful? You know, what should patients know about the physical therapy process?
That's a loaded question. How much time do we have? Yeah, so a patient comes to us sometimes from a doctor with like PT eval and treat with whatever joint it is. Sometimes they come off the street, they've seen us before, their friend recommended them to come to us. So something is hurting, they can't do something they want to do and they want to get back to doing that thing. So we start with an evaluation. We talk a lot about like their goals, what are they having trouble doing? And oftentimes in that subjective conversation, we're going to figure out what's going on. And then our objective, when we put our hands on and do our measures, that's sort of confirmation of what we gleaned from the subjective exam. So then like whatever we learn, like, do they have flexibility issues? We're testing their strength, their balance, their neuromuscular control. So all the components inside the body to figure out, okay, like what's not strong, what's tight, what's weak, what needs to be stretched, what needs to be activated. So all these things sort of tunnel us into our plan. And that patient's very involved in that plan. Like we want to know what they want to do, not just what we hope they can do. So their goals are kind of number one, and they direct the treatment. So then we give them exercises to do. If they need hands-on treatment or modalities, we do that as well. That's sort of like the comprehensive program. We can figure out how many times they need to see us. We're big on home exercise programs, and I'm always honest with the patient. Like, if you don't do the work, it's not going to work.
Yeah.
So just making sure like they're comfortable with what they have to do at home. I use the camera a lot, take videos of what we're doing so that they have no excuse to not remember what we're supposed to be doing. And then we do follow-up treatments to sort of progress the patient back to doing what they love to do. So that's sort of like PT in a nutshell. You said, is it painful? It can be, but that's not the goal.
Right.
We have pain rules and soreness rules, so we don't like to go above a certain number. If we're doing something and pain is increasing as we're doing it, then we want to modify or back off and figure out why that's happening. After an acute surgery and you're working on range of motion, getting motion back, like, sure, that's going to be sore, but it shouldn't be lingering sore. Like, it might be uncomfortable while we're doing it, but 10 minutes, 30 minutes after we stop doing it, it shouldn't still hurt. So if you're in PT and you're constantly in pain, that's not the goal, and that's not what we want to be doing.
Okay, good to know. Good to know that, that pain relief, you're mindful of that and helpful along the way to help patients progress gradually, with time. Becca, could you also share, if a patient does need surgery, how can you help them beforehand with physical therapy, like that prehab process? How do you help them beforehand?
I think thumbs up. We love prehab.
I love getting patients beforehand because
Good.
Dr. Fillar is a busy woman and she doesn't always have time to answer all the questions and she doesn't know all the tips and tricks. I'm sure she does, but she doesn't have time to do it. So I love having that hour with this patient before their surgery to answer all their questions. Sadly, personally, I've been through a lot myself, so I have a lot of tips and tricks that I can give patients that, to help them over that hump. It's just a nice time to sort of also get baseline data, like what do you look like right now? We try to get the home set up. Is there things that they can order to make the process easier on the back end? We tell them all about like, okay, like it's going to be a painful process. Expect that the first week or so is not going to be fun, but progressively it'll get easier. I try to emphasize that the first period or first phase of recovery needs to be slow. And if you try to go faster, you're only going to slow yourself down more, potentially just start this process over again. But yeah, biology has to happen. Things have to heal, and you can't make that go faster. You can make it go slower by doing the wrong things. So yeah, I get it. It's just a great time to hear their fears, listen to their goals, and then building that rapport with them as well before they have the surgery, so that when they come back, they're like, oh, I know you, Becca, like I'm comfortable with you. And it just makes the rehab process a little smoother on the backside.
Okay. And turning to Dr. Fillar, could you provide just a general overview of the most common types of surgical repairs that you perform?
Sure. So I do a lot of ACL reconstructions, knee scopes, multi-legs, MPFL reconstructions, rotator cuffs, labral repairs in the shoulder. So there's that component from a sports medicine perspective, but I also take care of a lot of patients who have knee arthritis and who end up having knee replacements. To the question about prehab, I think it is a wonderful tool, both from a patient perspective, but also for the physical therapist to get to know the patients and have them establish that relationship before the patient is now going through the rehab process after surgical intervention. In the field of athletics, we always talk about the more repetitions you have doing something, it makes you become an expert in it. So I personally feel that doing those exercises prior to surgery, particularly working on range of motion, working on balance, kind of dynamic control, makes a huge difference after surgery. I think people have muscle memory. You have an idea of what it should feel like. So that prehab can be incredibly beneficial from that perspective as well. The vast majority of the surgeries that I do, people are going to need physical therapy afterward. So for me, I definitely am going to rely on my physical therapist to help that patient get through that component of that. I think the surgery is one piece of the puzzle, but I think the recovery and the physical therapy afterward is equally as important. To Becca's point, it's definitely about the time that you put in. I think I have a wonderful job. I love getting to take something that's broken and fix it. But I recognize that there's a lot of responsibility from a patient's perspective too, to continue to do that biology, do that healing afterward to try to get the best results possible. So I think that having a good relationship with your physical therapist from a patient perspective is also hugely important. I think that communication between those two people is hugely important following any surgery. The other thing that I would say from my perspective is every surgeon has slightly different things that they anticipate or how they want the post-op protocol to be in terms of regaining range of motion or weight-bearing status. So the physical therapists are very good at taking that information and then applying it directly to that individual patient, because they may have had an ACL reconstruction, but the person next door may have had an ACL reconstruction with additional work, like a meniscus repair, that means that they can't be fully weight bearing, or they may be in a brace longer, or they may need to be on crutches longer. So having that physical therapist who knows this process recognize that not every ACL is the same, not every patient is the same, is very important. And then the other thing that I also rely on our physical therapist, as Becca alluded to, she sees the patients a lot more than I do even after surgery. I tend to see people in the office afterward for the post-operative check, but by all means, if Becca's seeing a patient 2 to 3 times a week, she has much more hands-on. So I'm also relying on her to be eyes and ears, and she has been doing this a long time. And if she has any concerns about how something is going after surgery, she can either reach out to me directly or get the patient in touch with me. So there's that component post-op as well that I think is very important. I just want to bring that up too.
Yeah, it's really on us when a patient comes in and it just says, or the patient says, I just had my ACL done, but they're not putting weight on their leg. So, okay, like, did you have a meniscus repair? Do you have other stuff done? So it's important that either or both, we talk with the physician, because they were literally in the knee. They know exactly what they saw and what they did. And also looking up the operative reports, so to have a better understanding of what was done, so we can help them the best that we can.
Great. Great. I'll direct this question to both of you. Speaking of, the recovery process, what should patients expect? And I imagine that this would be, that things would vary, the recovery process would vary depending on the type of treatment. Could you guys explain more about that recovery process?
I'll go with conservative route if you want to take a surgery.
Okay.
From a conservative route, like, tendon issues take a long time to heal. And so setting those expectations early on that we didn't get hurt overnight, it's not going to get better overnight. So tendon things just take a long time to heal. Having done this a long time, we sort of have these like timeframes in our head, so we know how long like a certain injury is going to take. Just having realistic expectations and communicating that to your patient is so important for those conservative things that, like, sometimes it just feels like there's no end in sight and it's going to be baby steps. Surgery is a little more concrete, I think.
I agree. And I think at least the way I would explain it to my patients would be that when you have your surgery, there's going to be increased pain, swelling, inflammation. So from a treatment modality, from what I would understand and what I would anticipate, Beck would probably tell people, is that they're going to be working on those things first to try to get the biology to be conducive to the latter part of physical therapy. So I think the first part is more probably biological, ice, more general treatment modalities. And then depending on the person, because everybody responds differently to surgery, kind of progressing with that individual patient. I think it's probably very hard to be a patient in physical therapy if you're working next to somebody who had a similar surgery, because some person may be doing really well with one particular part where you're struggling with something else, and vice versa. So I think that it can be motivational to see other people who have been through that. But I think working with a physical therapist who can help guide you and be like, no, this is your biology, we have to do things according to what your time frame is really, really important. So everybody kind of progresses within that time frame that Beck mentioned, but everybody is different. So I think recognizing that, and as she mentioned, bringing up those realistic expectations is important, whether it's conservative for something that's non-operative or something where somebody is recovering from surgery. Then I would also argue that probably the two of us work in a collaborative nature as well, in terms of like what's available on social media and TikTok and Instagram. And I think trying to deal with like what the realistic expectations are versus what you see online or what somebody's posting about versus what actually happens in surgery or in PT is hugely important as well.
I always say, like, treating the actual, like, we keep talking about ACLs, it's just something we see very often, but like anyone can treat a patient after ACL surgery. Like that's easy. It's the patient behind it that's the hard part. Like the actual knee, like that's easy. Like I can treat that with my eyes closed. But is the person working a full-time job? Are they, what level of play are they trying to get back to? Where are they in their season? Psychological component. There's so many pieces that go into it that affect.
Is this their first time? Is this their second time? Do they have kids? Right. Like what you're right, 100%. It's definitely very patient dependent.
Okay. And I think all of those factors that you guys just both described can factor into how long the recovery process can be. So I'll direct this question to the both of you too. If an athlete, has had surgery, typically how long of a period of recovery time is there? Like how much should they expect? I imagine this depends on the person
Depends
and
on the
how,
surgery
if
for
they
sure.
keep up with their physical therapy afterward, but how long typically?
I think, as you mentioned, it depends on what the surgery is. If I am going in, and doing a knee arthroscopy for a torn meniscus, and we're going to do a partial meniscectomy, which is, about a 25-minute procedure. It's just 2 small incisions. You just, minimally invasive, go in and just trim out that part of meniscus that's torn. People can be weight bearing as tolerated afterward, ice, anti-inflammatory medications. How somebody's body responds physiologically to that procedure can be very different. Some people, it's like nothing happened and they're like, are you sure you haven't operated? And you're like, I promise I did. And then some people are like, what did you do? Because the knee just gets more inflamed. So those patients, for example, I'm not going to let anybody really go back to cutting or pivoting sports for about 6 to 8 weeks, just because I think there is biology. You want to make sure you're functionally recovered, not just from the surgery, but also from a dynamic musculoskeletal control perspective, which I do think takes time for any body to recover. So something like that, maybe 6 to 8 weeks. An ACL tear, maybe 9 months to 12 months. They just did a recent polling of all the NFL head orthopedic surgeons, and nobody's letting any of their NFL professional athletes go back earlier than 7 months, and most people are pushing 9 months to a year. So I think that there's the recovery from the surgery part of this, which is the biology and the healing. And then everybody responds differently in terms of how long it takes for their body to actually recover from the stress and the trauma and the downtime and not being able to be up and doing regular movements. So to your question, which I realize was a very long-winded answer, I do think it probably depends on the injury. It depends on the athlete. It depends on what accommodations or kind of cheats that they're doing to kind of get through that. Do you have to unteach things? So I think we have a general window of time, like we would do treatment. For the stuff that's non-operative, Becca already kind of alluded to this. When I write a physical therapy prescription for tendonitis, I say 2 to 3 times a week for 8 to 10 weeks. Evaluate and treat modalities as indicated. I may say, consider eccentric strengthening exercises just to let them know I put some thought into this. But I try to leave it very open-ended because I recognize that some people are going to respond differently, and meeting with Beck and doing that initial assessment and knowing what the patient's goals are and what they want to get back to is so important. So it just depends, I guess.
And I think my next question, it's probably the most common one that you guys get, but and it's very important for athletes, but what do you consider when determining when the athlete is ready to return to playing?
This is definitely when I rely on the physical therapy. So
yeah.
I don't know if we could talk briefly about ACLs, but whatever you want to talk about too.
Yeah, I was gonna, of course, go to ACL, but first, like, no matter what the injury is, like, patient has to not have swelling, not have pain. Like, daily life has to be pretty pain-free, full range of motion, full strength when we're pushing on them. And then when we're trying to get to that next level, we have to have an understanding of what their demands of their sport are. What are they getting back into? So just having like numbers, someone sitting on my table, me pushing on them is not going to be enough to translate to like being a running back on a football field, running 3 people. So we have different criteria that exist. We have I work at USA Lacrosse. We have fancy equipment like force plates, biodex to test different strength and power. We do jump tests. We try to kind of put them through what they're going to be doing, simulating what they're doing in their sport to make sure that they're safe, they're strong, they're confident, and testing left versus right to kind of get an idea of like are there any asymmetries? Are they scared to put weight on the leg? Is the quality, that's really the quality of the movement is super important, not just like they're hitting these numbers, but what does it actually look like? it's very common to tear your other side after rehabbing the surgical side. So we try to make sure they're as close to 100%, if not beyond 100% before they're cleared to return to sport.
I mean, aside from the physical exam too, is from what I understand with the ACL, you guys also are doing questioning the patient too, because it's not just what can your body do. There is a psychological component to this as well. A lot of, if an athlete has an injury on the field, they may be structurally sound, everything may be fine, but from a mental component, the idea of having to get back on the field and go through all of that, I know that's not the vein for today per se, but there is a psychological component that goes to this as well. So it's also assessing that athlete's readiness to go back and willingness to go back.
Yeah, absolutely. So we talked a lot about the injury management, different types of treatment, and the recovery process. Could you share, is the sports medicine field moving towards more of a prevention-based approach?
Definitely in the PT world for sure. And I'm kind of like cautious to use the word prevention because I feel like there are many things we can't prevent. I like to say like reduce risk of injury because we can't prevent every like possible thing that happens. But I love getting patients in my clinic that maybe aren't hurt and just like I see a lot of runners, so doing like a gait analysis to identify any risk factors that potentially lead to injury because injuries are very common in runners. So getting the patient beforehand and assessing those things, it's critical and can definitely avoid major injuries, major setbacks, and then giving them those things to work on to hopefully keep them out of our office and out of the OR.
No, and I would agree with that. I think that, as much as you can prevent, as much as you can have a strong, stable base to begin with. I think a lot of athletic teams, high school and collegiate teams are hopefully have access to, strength and conditioning, that they're working on those things. We always encourage people to be multi-sport athletes to try to avoid the overuse, things like that. I think it's just, but we kind of brought up at the very beginning, being cognizant of what the potential injury risks are in that particular sport, and then maybe focusing on an injury prevention or a strengthening program to try to eliminate or reduce that risk as much as possible.
I wish I could see every athlete at least once a year, like they see their primary care. Like, can I do a primary PT visit just to identify things that they can work on?
That sounds like a good idea. Talking about reducing that risk of injury. Yeah, I think that'd be a good idea. Are there any, I'll direct this question to you, Becca. Are there any specific strengthening routines, stretches, or sports performance programs that could help prevent injuries or reduce the risk of injuries?
As Dr. Fillar just alluded to, like we connect a lot with our strength and conditioning specialists because getting the athlete strong is paramount to reducing risk of injury. And that, depending on like what age you are and how skeletally mature you are and how mature you are as a human being, plays into that, like when you're appropriate to do those things. But getting that into the mix as early as possible, learning fundamental movements is imperative. So yeah, as long as collaborating with the docs, but also our strength and conditioning specialists to get them in there and getting them as healthy as possible and performing as best as possible.
All right. And is there any surprising or recent science that guides your decision making? I'll direct this to Dr. Fillar.
Well, the nice thing about being at MedStar is that we have weekly didactic lessons on the whole spectrum of sports medicine, whether it's looking at Achilles injuries, ACLs, cuffs. So we're doing literature reviews and always trying to stay on top of what the newest options are. I think that kind of what I alluded to before with like social media and TikTok, you always want to take some of the newer things with a little grain of salt, make sure that there's good scientific evidence to back up whatever that treatment protocol is, whether or not it's an injection or something over like a wrap or whatever the case may be. So I think it's just trying to find that good provider that you can discuss what those different things are as in terms of like treatment options. So, I mean, I have a lot of people who ask me about stem cell treatments and things like that. And some things are borne out in the literature and some things aren't. And some things may be indicated for one particular injury and maybe not for something else. So I think it's just that collaborative environment also extends to the patient as well. So making sure that we talk about the newer things that are out there. but making sure again that they're scientifically sound.
Dr. Feller,
Absolutely.
I don't know if you agree with this, but I feel like earlier on in my career, it was more time-based, like, okay, you're at week 4, we do this, at week 12, we do this, at
Yes,
month, but now it's more criteria-based. So
definitely,
not
which
on
I think
time
is,
frames.
no, I think it's great. So I mentioned I had my ACL done when I was 15, and at 6 months, they're like, you're good to go. And I'm like, what? Am I? Like, what does that really mean? Like, I'm good. I just am back to playing sports now. Like, I could just go out on the field. So I do think that the criterion-based stuff is very important. I think from maybe I'm speaking out of turn, but like in terms of like the PT world, like looking at dry needling or looking at cupping or blood flow restriction. So there's certainly some quote unquote like newer things. They've been out for a while, but now they've been out long enough that there's a good body of scientific literature that supports that. So, I mean, I think it applies from an orthopedic perspective in terms of implants that we use, surgeries that we do, but I think it also applies to the PT world as well.
All right. And I'll direct this to the both of you, but feel free to chime in as you see fit. Why should athletes choose MedStar Health for their sports medicine care?
I feel very lucky to work here. I think that from a sports medicine perspective, it's everything is available in-house. There's not really, I mean, you can obviously go out into the community and have an MRI done at one location and physical therapy done at another. But I think that the nice thing for me is that when I'm looking through the patient's medical record, I can see what they've been doing with Beck in PT. I know her. She's going to send me messages if there are any issues. So I think that collaborative nature, the fact that it's kind of all in-house, makes it a little bit easier for the patient. They're not having to collect their own information from over here and then bring it to the next provider. So I think it's ease of access, and I think it's for the collaborative nature of things here.
I think people don't realize it's a huge team effort when an injury occurs. It's not just the human experiencing it, but the imaging, the doctor, the PT. Sometimes they see a primary care sports med, primary care first. So again, just having that streamlined communication, and I can literally walk down the hall and go talk to Dr. Filler and talk about a patient right then and there. It's quick and easy, and it's kind of, I don't know, it's hard to get that in other places when you're not all under one roof. So I love working with the providers that I work with, and I feel very lucky to do so.
And I think we also have a very high expectation of one another and the care that we provide for our patients. I think that that's really important too. I think everybody really wants the best for the people that we're working with and for the people that we're taking care of.
Absolutely. Absolutely. And finally, again, to the both of you, what do you most want people to take away from our conversation about sports injuries?
I would not ignore it. I'm always happy to talk to people. I mean, I occasionally have people who come into the office who tell me, this bothered me a week ago. I scheduled the appointment and now I feel fine. And I'm like, well, let's talk about what you were experiencing before. Let's do a good exam. We have a good baseline. So even if things get better, I think just knowing who that person is and like doing the prehab before of surgery or anything, establishing those relationships are really important. And then just knowing that, you know, if I've seen somebody for their knee, but now their shoulder hurts, they have a point of contact. If Beck's seen somebody for their hip and now their ankle's bothering them, she's available as a resource. So I just think I would want people to know that we're here for them, to talk to them about what is going on from an injury perspective or from an anatomic perspective, and then just being able to talk to people about what the options are to treat it, whether it's non-operative or operative, and just making sure that people can make an educated choice about their bodies and what they want to do.
For the more chronic issues, if we can like go into the office when the warning light's going off and not when the alarm bells are going off, that would be great. So if you could address issues quicker, you'd miss a lot less time. So if something is bothering you, get it checked out. Don't keep putting it off and make it a bigger issue. And yeah.
Absolutely. Great advice from the both of you. I really appreciate your time and you sharing your expertise. Thanks again to our viewers. That's a wrap for our broadcast. We appreciate you guys tuning in. To schedule an evaluation with Dr. Fillar, please call 877-34-ORTHO. and to schedule an appointment with Rebecca or any of our other physical therapy experts, please call 844-91-GET-PT. We're going to put that information and the numbers as well in the comments below. Thanks again for your time, and we'll see you next time.
Thank you.
Thanks.
Thank you, guys.